Delayed speech is a concern for any child who is 2 years and has not reached a vocabulary of more than 50 words. Above and beyond the vocabulary, specific communication skills should be present. Communication skills include shaking the head, nodding the head, social etiquette, greeting, pointing. It is especially concerning when delayed speech is accompanied by hyperactivity, selective talking, and an incredible understanding of shapes, numbers, colors, and sometimes songs. What we have to note is that delayed speech impacts on a child's learning even at school age and at preschool age. Oftentimes, not speaking is accompanied by reduced understanding of language. You speak what you understand, you respond to what you understand. Without the ability to understand the basic communication skills, it will be difficult to acquire the complex language and the complex skills that are needed at preschool and at school age. Late emerging milestones impact on the successes of needed later in life. For example, all children should follow the hierarchy of development. Skipping any stage or being late at one stage will actually impact on the future development. For example, if you can't crawl, walking will be difficult. If you can't walk, speaking will be difficult as well. So you want to develop and use that hierarchy of development in any time and place. As speech therapists, we are trained to pay attention to a lot of things at the same time. We look at the facial expressions, the body language. We note the sounds or the vocalizations that one speaks. We look at the interaction between a child and their family, their mother versus their father. We also look at the interaction between themselves or other children or siblings. Interaction with a child goes above and beyond the physical. We are taught to understand the psychology of the child first. What do they respond to? How can we make it fun? Fun is meant to be the order of the day for children. I'll give you a summary of what you have to know at the back of your head when interacting with the child. First, your voice. The loudness of it, the varied pitches and the tones contribute a lot to how much your child is attending to or listening to what you're saying. You have to get into character. Number 2, use a lot of onomatopoeia. So that's where English came in. Onomatopoeia is the sounds or my example of the sounds that are made generally. So, for example, the child fell down. Whee! He's sliding down the slide. Woo! Bang! Closes the door. So that's basically onomatopoeia. Number 3, play as much as you can with the child. While playing, say everything that you're doing, how you're doing it, why you're doing it. Number 4, reduce the frequency of saying no. No is only reserved for certain situations which you have to express your boundaries. Rather, insert words like, oh no, I don't think so, try another one, try again. Number 5, reduce the number of questions used to elicit an utterance. What, why, when, let's reduce all of that. What actually happens during a speech therapy consultation? Generally, you attend your very first interaction, and that is called an assessment. During the assessment, there will be 2 segments. The interview segment, whereby you talk with the speech therapist, state your case, why you came there, a deep understanding of what and how we can expect during our therapy, our assessment session is given during the interview. There are a series of questions that will be asked, ranging from what's your biggest concern, what's your least concern, the strengths that the child has with communication, the weaknesses. We want the medical history. That is very important. We want the birth history, if you have it. We then move on to the second segment, being the interaction with the child or the patient. Depending on the reason for wanting the consult, we assess what is necessary. What can they do? What can't they do? Why do we have the gaps? Why do we have the strengths? What are the strengths? When are these strengths seen? When are these weaknesses noticed also? Then we have feedback thereafter, whereby we give the caregivers or family a preliminary speech therapy diagnosis. We relay our clinical decision to ask for another opinion from a pediatrician, from an occupational therapist, an educational psychologist, or a physician. The opinion is necessary because we see that this communication disorder or this communication delay does not go in isolation, but it has other characteristics which point to an additional diagnosis. That is when we ask for another rationale for communication disorder. We often say it's a communication delay secondary to a medical diagnosis. During the feedback, we also give recommendations on what to do at home so far. The next time I see you, it would be a treatment session. There, a range of activities are done. Specific targets are planned. There, we note how many times you have responded to what has been taught. We repeat. Have you used the language that we have planned? Have you written or read the targets that we have planned for? Are they spontaneous? Were they probed? Was maximum support needed to actually get to the spontaneous responses? Did you note your mistakes? Did you correct yourself as the child? How often did you correct yourself? Thereafter, the treatment session, feedback is then given to your family or your caregivers. At this time, we then give specific activities that you can continue with at home.